MIB Agents OsteoBites webinar and podcast presents the latest in osteosarcoma treatment, research, innovation, and hope each week. Today, we're speaking with Dr. Pete Anderson of Cleveland Clinic about understanding lab, pathology, and scan reports, and other questions. Our All Osteo Warrior panelists today includes our 2021 junior board members, Delaney Sweet-Wernicke and Kara Skrubis. Also, Osteo Warrior mom, Allie Murdoff, and I'm your host, Ann Graham, president of MIB Agents. Welcome to OsteoBites, everybody. Get your snacks. I brought my hobnobs, maybe took a bite already, which is totally appropriate because we're hobnobbing today with Dr. Pete Anderson, affectionately known as Dr. Pete. He is an MIB Agents board member and scientific advisory team member. He is a professor and practices pediatric hematology-oncology at Cleveland Clinic. He also practiced at University of Texas, MD Anderson Cancer Center, where we first knew of each other. He was the section chief there of non-neural solid tumors. He was at Mayo Clinic, where he launched the pediatric bone marrow transplant program. He received his medical degree from Mount Sinai School of Medicine and had his residency in both internal medicine and pediatrics at Duke and fellowship in pediatric hematology-oncology at University of Minnesota. Today we have an all Osteo Warrior panel with, very excitingly, our 2021 junior board members, Delaney Wernicke and Kara Skrubis, and Osteo Warrior mom, Allie Murdoff. And I'm your host, Ann Graham, president of MIB Agents. MIB Agents, just FYI, is a pediatric osteosarcoma nonprofit dedicated to making it better for our community of patients, caregivers, doctors, and researchers, with the goal of less toxic, more effective treatments and a cure for this aggressive bone cancer. Our mission is in our name, MIB, make it better. We make it better in 3 ways: through direct patient and family support. If you need support, please go to our website and look up programs. We have lots, really excellent programs. Education through our Factor Conference, through OsteoBites, and through our testing and research directory, and of course our book, which is available for free download, or you can get one as well in the paper, I guess, as opposed to in the flesh. It's available in Chinese, Spanish, and English. And the third way we do this is through research, through sharing it, through funding it. More on that later. If we can be of help to you, please let us know. If you would like to join our shared mission to make it better, we also want to hear from you. Whatever it is you do, do it for kids with osteosarcoma. Please, whatever magic you have, we need it to help improve osteosarcoma. With that, Dr. Pete, would you introduce yourself, please?
Thank you, Ann. Not a whole lot more to say other than it's a pleasure to share and show that we really care about not only following recipes, but knowing how to cook. So we'll learn a little bit about that today.
Hi, my name is Kara Skrubis. I'm 19 years old. I was diagnosed at 18 years old in January 2020 with osteosarcoma. I went through 9 months of chemotherapy as well as a left above the knee amputation in April, and now I am doing immunotherapy.
Hi, my name is Delaney Sweet-Wernicke. I'm 17. I was diagnosed in 2016 when I was 13 with a 10-centimeter cancerous tumor, obviously, in my right pelvic bone. I had limb salvage surgery and I relapsed in my lungs multiple times.
Hi, I'm Allie Murdoff, and I am a mom of an osteo warrior named Charlotte, who was diagnosed in 2018. And she is currently in treatment right now, so I'm just stepping in for her, and I'm really happy to be here.
We'll talk about labs, path report scans. I don't have any disclosures except I love winter. Now, there's a few additions to the slide my dream team added into here. So I'll give you an example. Today is a great day. I wake up early in the morning and I can go ski on the golf course and do 18 holes before I start work. And to me, that's the definition of good winner. We'll be evaluating information, but there's so much information. How do we sort it out? We have Epic as our EMR at Cleveland Clinic, but it also has this function called MyChart that has everything. And we'll provide a framework so you can evaluate some of the mountain of information to make it better. But also if you do what I call deliberate practice to improve health, then it just gets easier and easier. And of course, ask questions of your care providers. So first of all, labs. Just about every visit seems to involve CBC with differentials, sometimes chemistries, and then we'll talk about an index of inflammation today too. So what happens to all these tubes of blood? The CBC really means complete blood count. It provides you with numbers of red cells, white cells, platelets, but it's incomplete unless you tell what kinds of white cells, and that's what the differential means. In most clinics, they turn this around pretty quickly. In our clinic, it's about an hour. It's used to make decisions about not only infectious risk, but whether or not to get chemo or to wait, and whether you need a transfusion or to wait. So when we look at the red cells, myself, I just look at the hemoglobin. If it's greater than 10, you're A-okay. 8 to 9, it's low, but you might be feeling just fine. If it's less than 8, the question is which direction is it going in, or do you transfuse? So it's not the absolute number, but sometimes the symptom, the trends, and how fast it's falling or rising. We also get other information from the CBC. They'll tell us the size of the red cells. That's the mean cell volume. RBC indicates how many red cells, but most hematologists ignore that little line. And the new red cells are called reticulocytes that can help you break a tie, whether somebody's going to be making blood soon enough that you can just wait, or they're not making much blood, many new red cells at all, in which case they might need a transfusion. So when you look at types of cells under the microscope, there's really big white cells we call polymorph nuclear cells, PMNs or neutrophils. These tiny dots, which are platelets. There's smaller white cells called lymphocytes too. And of course, the many discs that are the red cells. So the neutrophils seem to be what the doctors are focusing on the most. This big white cell has many lobes. That's why they call it the polymorph neutrophil. And they fight bacteria. Without them, we'd have bacteria from our mouth, intestines, rectum, get into our bloodstream. So you need these to kind of provide a barrier. And the way we figure out do you have enough is the absolute neutrophil count. And that's basically the total white count times the percentage of neutrophils. If it's over 1,000, you're okay. This is maybe not. This is, if it's under 5, it's low. And you don't have enough to fight fever sometimes. So you have to follow the trend. Now, if you're going to get chemo, you don't want to give it to somebody whose white cells are getting less and less. So we wait until the ANC is greater than 750 for the doxocisplatin cycles, or 500 for the high-dose methotrexate, which doesn't affect the counts as much. Also, these numbers are in our recipes for our protocols. So many times, the doctors will just look at it. You'll be close, but not quite enough. That's okay. Or you'll just make it. That's okay. They're guidelines, but so we all practice in a similar manner. After you get chemo, then the white cells get less and less until they're at a low point. We call this the nadir. And then you get recovery. you want to start chemo when the ANC is rising, not falling. So can you make the ANC rise higher and more quickly? We do this with growth factors. Neupogen or a biosimilar is where you get daily shots, or long-lasting is Neulasta or a biosimilar. Well, what about the other white cells? The lymphocytes are actually more important than many people realize. They help us fight viruses. They help us fight parasites. If we have low lymphocytes, we can get a opportunistic pneumonia called pneumocystis. That's why many people are on Bactrim when their lymphocytes are low, to prevent that. But the more lymphocytes you have, it's associated with better survival. So we call the absolute lymphocyte count the ALC. That's the total white count times the percent lymphs. And you want to make this better so you have better survival. This is a paper that was published 10 years ago. I remember being the reviewer that accepted it and wrote the highlight. Basically, the recovery of lymphocytes was as important as percent necrosis in terms of figuring out who would do well or not. So if your ALC was low, you had less survival. This is after one cycle of chemotherapy, did your ALC recover quickly, then you had good survival. So many times when we review path reports, I'll review not only the percent necrosis of the primary tumor when it's taken out with surgery, but the ALC too. We talked about trying to make sure you don't get pneumonia if your ALC is low, but also you can have inflammation, and whether this is tumor dying, toxicity from chemotherapy, surgery, infections, if the tissues are making this inflammatory marker PGE2, it'll inhibit the immune system and what we call damage-associated molecular profile. You want it to become an immunogenic cell profile. So these lymphocytes can kill the cancer. So there's a lot of reasons to reduce toxicity, and one of them is to help the lymphocytes work better. Platelets are the tiniest cells we see under the microscope. They're these little dots, and they help blood to clot. You don't have a whole lot of increased risk of bleeding unless they're really low. Then it's usually mucosal bleeding, like nosebleeds. And you follow trends. So it's not like all of a sudden you're 11,000, you're okay, and 9,000, you're terrible. But it's how fast it's dropping to near zero. Sometimes I'll joke, at the rate you're dropping, you'll be in negative numbers, which is, of course, impossible. But that's how you decide when to give a transfusion sometimes. How about chemistries? Now, this is an even longer list of lab tests that come back during a visit. We look at the blood urea nitrogen, the BUN, and the creatinine to look at kidney function. Alkaline phosphatase is an underused bone tumor marker. When you see new bone formation, or you have a bone forming tumor like osteosarcoma, the alkaline phosphatase can be real high. Sometimes when patients come in with really big tumors or lots of bone metastases, I'll tell them there's 3 things you'll know how your treatment works. The very first is your pain will get better. But then when we check your chemistries, we'll see this alkaline phosphatase go down. It'll get better and better. We'll know your treatment's working by looking at this before we even do a scan. The other chemistries we look at, particularly in osteosarcoma upfront treatment, are the liver functions. These will be high because such a high dose of methotrexate temporarily damages the liver, but the liver is a very, very resilient organ. And within a week or 2, they become normal. So you can have really high enzymes from the liver getting into the blood, but it doesn't really mean your liver is permanently damaged. It's just a temporary thing. Albumin's another thing that comes back on the chemistries. This shows how well the liver is making a protein that's associated with a lot of functions, but basically we think of it as a marker of nutrition. Higher is good, lower is bad. Magnesium is a metal that we see in the blood, but it's also a cofactor involved in energy. So if your magnesium gets too low, you can get fatigued or extra symptoms. And cisplatin tends to cause the kidneys to lose magnesium. So many patients, after getting osteosarcoma therapy with cisplatin, will be checking the magnesium and deciding how much to replace. It's a temporary thing, but unless you check, you don't know. And then phosphorus is another thing we look for chemistries. I think this as a real good marker for ifosfamide. It'll become low after ifosfamide, but then it should be normal before the next cycle. So another underutilized test is the C-reactive protein. Low is good. This means you have low inflammation. High is many causes. You don't get an answer why it's high, but it helps you to try to figure out what can we do to reduce inflammation. And usually that means reducing toxicity or making sure that there's good wound healing. So one of the other things that people can find very confusing are pathology reports. It's the pathologist's job to describe everything they possibly can about the tumor that will help you with diagnosis, when the surgeon took it out, how close is where they cut the tissue to the tumor. They actually ink it so that when they look under the microscope, they know how close the tumor is to the margin. 1 millimeter can be enough, but we like to see centimeters, and that's not always possible. They'll also make a grid of the tumor, and then they'll try to come up with a figure of how much of the tumor is alive or dead. Many things influence this, not just how well the chemo's working. Sometimes it's a big tumor with pressure inside the tumor, the blood supply of the tumor, as well as how well the chemo works. So if there's confusion about the percent necrosis or the margins, it's okay to have a second opinion. Pathologists are actually quite collegial and will help each other out sometimes with more details that are more understandable. How about radiology reports? Now, they can be very confusing. It's almost like another language. They can be very, very wordy in a bunch of different parts, whether it's an impression or detailed description of everything that the radiologist sees. What they're trying to do is describe pictures with words, and they don't mean to scare you, but they don't want you to miss things. So what kind of story are they telling? And I think the big message is don't panic. Sometimes it means getting more information or actually looking at the images. Now, the images are pictures, and when you think about it, a CT scan may have hundreds of pictures. Sometimes MRIs have thousands. So how do you distill all that information into 1 or 2 page report? It takes a lot of effort, but it also takes organization. And there's vast differences I've seen in the quality of reports. Sometimes you think they're in a rush. Sometimes you think they have all day, and they put it in such detail, it's difficult to wade through. So there's many confusing terms that make it sound sometimes worse, like regression or new or ground glass or larger, when it's only a millimeter difference. And then I'll actually show the image to patients in the clinic, and I'll say, a millimeter is this much, or a new nodule is, 8 millimeters. It sounds big, but it's smaller than a raisin. So slow down, ask to see the images if you don't understand the report. The best case for radiology reports is the a radiologist will describe each finding, where to find it, so which series. Of that series, there might be, 100 images. Let's say series 3, image 34. Even then, they'll need to sometimes point out it'll be in the front, anterior, or to the side, laterally, at the edge of the lung, plural, instead of just saying it's on this image, and then you're trying to find some tiny thing. New findings should always be compared to old scans, and they should tell you which scan they're comparing it to. High achievers, sometimes I have yet to see this in a radiology report, but sometimes I use it to provide perspective. Do all of you remember how you find the volume of a sphere and ellipsoid from geometry? You think you'd never use this ever. I use it probably once a week because it helps me be more optimistic. So you look at the size of a tumor that's shrinking, and it's 4/3 pi r cubed equals the volume in cubic centimeters. So sometimes you'll say, wow, that's really shrinking good. I did this on a recent patient with sarcoma, and it turned out when I compared the volumes, it was 1/10 of the original one. And you don't appreciate that unless you actually do the measurements and then the calculations. So seeing is believing. A high achiever oncologist will have made a PowerPoint with legends so that they're prepared to go over the report with you. If they don't have enough time to do this, you can always say, well, I'm glad this is the big picture. When we do the next ones, I'd like to see the trends, and hopefully they'll take the hint and really help you understand which direction you're going in. The other thing I've enjoyed doing, and when I was recruited to Cleveland Clinic, I remember asking them for this. I said, I don't want a giant big salary. Of course, I'd like a giant big salary, but one of the things that would make my job more enjoyable in a teaching institution, instead of just having a workstation where you work on the medical record, a real computer, so that you can show PowerPoints. You can also use the snipping tool to create images right in your note. So when other doctors look at your note, they have pictures. Now, I have to admit, when I read the newspaper or magazine, I'll stop and look at the pictures. Same with articles. So if you can illustrate your note, then other doctors will know what you're doing. So in summary, we have many opportunities to use labs and reports to make it better. Often it's following trends, connecting the dots that allow us to figure out how to have fewer side effects, an adaptive approach to make it better. And as you learn how to do this, learn more, ask questions like you're doing now, and we'll give you the opportunity to ask questions. So I'll stop the sharing and open it up.
So we have the question, what role does genomic sequencing play? Are patients typically sequenced? If yes, do clinicians get NGS reports from Foundation, Tempus, Guardant, etc., as part of the treatment protocol?
It's variable. We're doing this more and more. Some places will treat it like a path report and automatically do it. We often will discuss it at a tumor board and then decide whether we do it. We've come to the realization that in order to provide information not only about the tumor, but about your germline DNA, like Mr. Rogers says, just the way you are. Sometimes you have predisposing mutations. So we've hired a genetic counselor, Brittany Griffin, to help us with this task. So she'll do two things. She'll talk to the family and say, we'd like to send your tumor off for extra information, But when we do, we need to make the best use of that information, know some information about your own genetics. So we tend to use Tempus at Cleveland Clinic, but every center will either have their own panel or their own pattern of practice. What I'd like to see is the genetic information get more in depth to the point where it's not only instantly understandable, which is hard because there's so many abnormalities in osteosarcoma, genetic information for each patient, but to store it in a database. So hopefully in the future, if we ever make vaccines, people will have that information, and they'll know which sample was tested and how to get more information out of it. So I'd say it's gradually becoming the standard of care, but there's no specific one that's the frontline winner yet. I like Tempus because the reports are easy to understand, they're friendly. They'll also allow me to send 2 samples at once that you can compare to see if they're different. So they've gone out of their way, I think, to make it friendly for pediatric tumors like osteosarcoma.
Is FOS elevated when you have lung mets?
So ALK FOS, sometimes, especially if they make bone. And sometimes you'll see this, and you'll actually not only look at the lung windows, but you'll look at the bone windows and say, oh, that little nodule's making bone. Sometimes they don't. There's another way to look at bone formation, that's to do a bone scan. It can be either a technetium-99 MVP routine bone scan that you can fuse to CT, or a sodium chloride PET bone. But I like the ALK FOS because it's such a simple test, and you can do the trends with each cycle. If somebody has either a tumor which makes a lot of bone or bone metastases that seem to make more than lung metastases. I'd say about a quarter of the patients with lung mets you'll see a trend with the alkaline phosphatase.
I have 2 questions related to being neutropenic. One is, when you're looking at recovery, do you look and focus more on the lymphocytes or the monocytes number, and how come? And then I'll ask you the second question after that.
Well, the first ones to recover are the monocytes. That's when your counts are really, really low. Then comes, especially if you're on growth factors, then the neutrophils, and they're pretty quick. The lymphocytes will have not quite as big swings, but they'll also recover some. In terms of recovery, there's also this phenomenon of once you're past the peak of making a whole bunch of white cells, then you'll be post-nadir and they'll drift down. That's okay. Your infection risk is low because you might be lower, but you're not super low. So again, it's kind of looking at the time course that helps. The other thing I think that helps you understand how fast recovery is happening is just looking at the window that you're looking at. The low point for the commonly used osteosarcoma regimens, whether it's doxorubicin, cisplatin, or higher doses of ifosfamide, usually you'll be at your lowest about 7 to 12 days after you start. And you should expect recovery soon after that, especially if you're on growth factors.
Thank you. And then the second part of the question is, is there any way to help increase that number in addition to like Neupogen or Neulasta, or is that really the only ways to help raise those numbers?
For neutrophils?
Yes.
One way we see it go up is if you're on Decadron, but that's kind of cheating. That just makes it higher because they don't cling to the blood vessel walls as much. I think probably the people with the best neutrophil recovery are the ones that, if they're losing the cycle, they seem to recover more slowly.
What is the significance of increased LDH in cancer patients? How high is concerning, and how often should it be checked?
LDH will also be high in metastatic or large primary osteosarcomas. It's not quite as specific as the alkaline phosphatase. We follow LDH in Ewing's because Ewing's doesn't make bone, so it's kind of similar tumor marker that way. It's also sometimes a false positive depending on how the blood is put in the tube. The way to think of it is somebody just jams the needle in the tube, and the blood goes in very fast, and you see all this foam. Then your LDH will probably be high because some of the red cells are broken up. We call that hemolyzed. So LDH will be released from the red cells, then you get all worried for nothing. If I see a high LDH, I'll often get it rechecked. And then when it's rechecked, I tell them make sure whoever puts the blood in the tube, it's like pouring beer, you don't want any foam. And so if they do it like that and it's still high, it's probably real. So it's kind of a hint that you have more tumor, but it's not as specific as alkaline phosphatase for osteosarcoma.
Does a radiologist typically sit down with the patient to read scans, or do they always send it to the oncologist to go over with the patients?
I would say 98% of the time they'll read the scans, make a report. The report will go to the oncologist, and that's up to us to be the interpreter, if you will. There are exceptions, and Hakan El-Islam, who's our bone radiologist at Cleveland Clinic. If I call him, he'll come over to the clinic. And particularly when we're looking at things like, can we freeze a lesion? He'll come over and explain how it's done and show the patient the scans. Nuclear medicine's a tough one because they not only look at the CT, but they look at how bright the lesions are. So their reports for PET CTs have to be quantitative. And so I haven't seen any of them come over to our clinic yet, but the vice versa is very true. There's many times I'll go over and I'll say, I need some information about this area, and then they'll talk to me. Also, if I think there's been less than high quality outside imaging coming in, they'll do, as a favor for tumor board, they'll create the images in 3 dimensions, and they'll also do a second read so that when we discuss them, we've got better images. But the radiologists, they're kind of in their own little group, and I think they'd like more patient contact, but I think it's just how they're set up that it's hard to do, particularly now.
After initial treatment, why is a CT scan the only test done quarterly to check for a relapse? How do you check for osteosarcoma that does not return to the lungs, but maybe to other bones other than the primary site?
That's a great question. 4 out of 5 times at least, it'll be in the lungs. The 1 out of 5, it's half the time lungs and bone. and it's only about 1 out of 10 where it'll be bone only. If it's bone only, generally there's symptoms. You'll have pain where you had your limb salvage if it's a local relapse or a bump. Sometimes what we'll do for high risk patients who either start out with bone metastases or they've had a close margin, we will do serial imaging of the area that we think they might relapse. So it's not just lung only for everybody, but we try to be judicious in ordering scans that have a low likelihood of showing up anything. Also, the chest CT is super easy to do. It doesn't take much time, whereas the MRIs take a lot of time. Let me ask one of the panelists, how long does the chest CT take versus an MRI?
I think I've had an MRI that was like more than 2 hours, and my chest CTs are usually like 2 minutes at most.
And a lot quieter.
Yeah. So, some of it's just practical considerations too.
When magnesium or any other mineral is low after treatment, do you ever recommend taking a tablet or vitamin to boost it?
We'll recommend magnesium replacement, particularly after cisplatin. Same with phosphorus if it's persistently low. Once in a while, calcium if they've had, let's say, radiation, and we know their bones need some extra calcium to heal. Most of the time, you can get all these things in your diet if it's normal. We're blessed with nutritionists in our clinic. She's literally 25 steps from the exam room. So what I'll commonly do is a combined approach of making sure Sarah, our nutritionist, will talk to the family as well as we'll offer them supplements. But if they can learn the principles of good nutrition, replacing things that should be in your body anyway, that's probably the best long-term way to do it.
Can circulating DNA be used as a biomarker?
It can in some circumstances, but the problem is the signal to noise ratio. All the DNA from the white cells kind of is like a ton of DNA compared to the few molecules from the tumor that escape into the bloodstream. The techniques are becoming more and more sensitive, but also more and more specific. But unless you know exactly what you're looking for in terms of a tumor marker for the circulating DNA to amplify that signal, it's hard to do. For Ewing's, it's much easier because you know which translocation and which gene. For osteosarcoma, it would mean getting more individualized information on the deep sequencing. So it's instead of just saying, oh, that gene's mutated with a point mutation, we need to get a number of genetic abnormalities and amplify them all. And so they kind of cross-check each other. And we haven't gotten there yet with osteosarcoma. I think someday we will. It's amazing to see the cost of genetic testing, how quickly it's gone better and better, and how it's more and more in depth. So I think it's just a matter of time.
They say, we are quickly approaching my son's year out of treatment. I have seen that a lot of osteosarcoma patients get mepacked after completing treatment in other countries. Is this going to become stars here in the US as well? Or are there certain requirements for it to be used? Are there benefits to having it versus not having it?
There's a lot of benefits, whether it's metastatic or not, that can improve outcomes. It's a long story why it didn't get approved in the US and it's approved in Europe. Mexico, Israel, Switzerland, Taiwan. I remember getting it approved in Taiwan. I flew there, and they said, "Well, why should we approve it when your FDA didn't?" And I said, well, "We have more information. We have a mature data set from 2005 of the primary study that shows overall survival. You can't fake that. You're either alive or dead. And also we have the access study with over 200 patients that did better than expected." What it takes is your oncologist to take a deep breath, have lots of energy. For me, that means morning, not afternoon, and to do the paperwork that's needed. I've taught many doctors how to access it through the Clinigen Takeda site, and then they say you're eligible to get it. Then you use that information. The FDA is actually very friendly. I called them up today. They were amazing. It's like, do I have to submit through the portal like, a company? Because they do this during COVID now, or a study, or can I just send you an email to Project Facilitate? So, oh, we're still doing the emails, and you obviously know the 5 pieces of paper, the PDFs you need to attach. Just send it to us, and we'll turn it around within a couple of days. So they send you the IND number, then you use that to go through your research board, institutional board at your institution. So you have to have a consent form. Once you have those steps, then you circle back to the maker of MeatPact and say, we've done all these steps, and then they ship it. So it's a daunting task if you haven't done it before. But once you're used to it, it's not so bad. I think to get it into the US, we're going to have to make it work better somehow. Either pairing it with another drug or using some sort of mechanism to make the macrophages and lymphocytes work better. And it'd have to be funded not through Takeda, because it's such a small market, they're not going to make money. But through an organization like MIT or other organizations, pooling their resources. So we're a ways from getting it approved in the US. Will it ever be approved in the US? I hope so. I encourage you all to write Dr. Trucco and say, you should be the one that develops the better MeatPact protocol. and the rest will be history. But I think you'll have to come up with a better mousetrap in order to get enough enthusiasm to do it.
How do you decide whether to get a bone scan or a PET scan? Is it lab related?
They provide different information. The bone scan tells you where you're making new bone. So for a bone forming tumor like osteosarcoma, it can be quite good. Also, bone scan's cheaper. It's under $1,000. So at initial diagnosis, bone scans can be standard of care. PET scan tells you how the tumor is trying to grow, how much glucose it takes up. The PET scan is very good at looking for bone metastases. It can also tell you trends. It'll give you a number, how bright that glucose uptake is. So for following the primary tumor, it can be as good or better than the MRI, trying to figure out, are you responding? I tend to do the PET scan up front. Getting prior authorization is harder to do for PET scans, so that can delay things sometimes. If you're on Neulasta, all your bones seem to light up because you're making so many white cells. So it's I would say, decision based on their capabilities in their hospital, as well what kind of information is needed. Sometimes I'll get both.
Should a patient with a MYC amplification receive scans more frequently than other patients?
Oh, that's a tough one because they're probably at higher risk for bad things to happen. So, the easy answer is yes. But the question is, what kind of scans, how often, and for how long? Probably the way to approach a situation like that is I call it expect the worst, but hope for the best. So you develop a risk adapted approach based on how far out they are. So even if you do study them more often, there'll be a point where you back off. Also, because I can't remember everything I tell a patient, believe it or not, I have a summary that tells me what we agreed on at the end of therapy so that it's kind of logical and predictable. And that way everybody's literally on the same page.
COVID vaccine. We've gotten this question like 5 times, and all different variants. If I'm on pazopanib, if I'm on Mepact, if I'm on MAP right now. Any thoughts on that?
I think it's a good idea to get the vaccine. It's equally good, if not better, if their whole family does. Because how are they going to get COVID? They're going to get it from their family. So it's kind of like the teachers in the school. They don't want to open up all the classrooms until the teachers are immunized, and then everybody feels better about it.
Mm-hmm.
So it's kind of a two-pronged approach. It's not just the patient getting the vaccine, but their parents and family members and who's ever in their bubble. In terms of responding to the vaccine, it apparently is extremely immunogenic. So even really old people found a real good immune response. So given what we see with osteosarcoma patients rarely having opportunistic infections, they've got some ability to mount immune responses against viruses and fungi and things like that. I bet they would respond to the COVID vaccine. Which one to get? Either the Moderna or the Pfizer, whichever one's available.
Is there any benefit to doing Mepact more than once?
That's a great question. If you can get it more than once, there probably is. On the other hand, instead of just relying on a medicine, local control measures always go hand in hand. So you want to get down to as little or no disease on scans before you would try it again.
Do you think that treatment and response has been improving for osteosarcoma patients living longer, which is resulting in tumors appearing in more non-typical locations?
Oh yeah, I've experienced this one firsthand. So if you have the second, third, fourth, fifth, sixth relapse, you'll start seeing odd locations. What you hope is that the further out you are, the fewer metastases you get with each relapse. They're what we call oligometastatic, just 1 or 2. The problem we see is if you never get down to no evidence of disease, then you tend to see the odd location.
I'm going to mess up this drug name, but can you share your thoughts on eltrombopag? I think the brand name is Promacta.
Yeah. Interesting. We're seeing it used more and more to help platelet recovery. It's very dependent on how bad your platelets are, how much you need it, whether your doctor's willing to do the prior authorization with the insurance company, whether it'll have a role that's increasing, we'll see. but for patients who have persistently low platelets, it can be quite helpful. It seems to have relatively few side effects. It's also a pill, so it's not as hard to get.
The really exciting questions, the burning ones now. Um, we'll start. We'll shorten your list a little bit because we bombarded you with so many questions today. But Cara, can you ask a couple of those burning questions, please?
Yeah, so the first one I have is, would you rather repeat high school or med school?
Oh, med school. Although I'm a high school dropout. I really am. And high school was hard for me because most people didn't know why they were going to school. So it wasn't a great learning environment, whereas college was. And in med school, there was more information than you could ever hope to learn. So med school is a lot more fun. Also, the nice thing about medical school was it was a time in your life where you were just learning so much. And for me, I was actually doing an MD PhD, so it's doubly fun. So I would repeat it in an instant.
What inspired you to be a researcher?
Oh, that's an interesting question. I needed a summer job, and I had a professor who I took a graduate level course as an undergrad, and I did better than the graduate students in the course. So he said, if you're interested in research, see me. And the rest is history. I talked to him, got a job in this lab, really liked the problem solving and how they could take one particular problem and look for a scientific solution. Also, they're fun people to work with. So most labs are relatively small groups of problem solvers, and you'll learn a lot about people doing research. It's not just working on your own. Like one of my life lessons was this mentor would go on a 2-week vacation, and then he would come back 2 days early and just walk through the lab and see who was there. So when the cat's away, the mice will play. So they walk through the lab, but it was a chance when he was away. I got to use all the equipment. So it's kind of funny how you find a niche, but for me, it was looking at how to really drill down on problems and try to figure out the solution. And a lot of research is trial and error and failure, but then trying to figure out why the experiments work or don't work. And then if you don't share that knowledge in a paper, then it's like never happened. So I like writing, so it's a good fit.
What other profession would you like to attempt?
Oh, there's so many. Probably the one that intrigues me the most would be just a facilitator. I call it a catalyst for good. So kind of like, you see these old people go to their oncology appointments and they're like sheep without a shepherd. So it would be real fun to just say, I'll be a fly on the wall, but one who talks when he's talked to. So that would be real fun for me, because that way they wouldn't be so afraid of getting the care that they need or deserve.
What is your favorite snack?
Oh, Oreos.
Oh, yes. Yes. Wait,
It's
double stuff or single?
probably single.
Oh,
But,
come on. You
but,
call yourself an Oreo fan?
but it's kind of funny. We used to make chocolate chip oatmeal cookies all the time when my boys were young. But now that they're older, they still eat Oreos. So when we get together or go on canoe trips, that's a must.
Yeah, my current practice is trying to pass them in the grocery store because I know if they come home, I think about them all the time. Like until they're gone, I can't have them in the house. It's a bad idea. Okay, gosh, that was so cool. Thanks, everybody. Let's see, exciting announcement at MIB as we wrap up our session here. For the 5th year in a row, MIB Agents is awarding $100,000 to osteosarcoma specific research. We're able to do this thanks to our MIB patient families through our family funds. You can find out more about family funds on our website. In the meantime, our family funds, huge gratitude to them for making this grant happen year after year. Our family fund members and our scientific advisory board will meet virtually this year to review and vote on the top 3 finalists. Those 3 finalists will present their proposals here on OsteoBites, who will then get to vote and determine the winning project. Totally a truly all osteo community effort to make it better. If you're a researcher or have awesome osteosarcoma research, go to mibagents.org, outsmarting osteosarcoma to find more information. Next week, we're talking with Dr. Lore Randall. His topic is sarcomatology, a transdisciplinary approach. He is a sarcoma surgeon, educator, and researcher, and the chair of the Department of Orthopedic Surgery at UC Davis. So that's going to be really interesting, especially the transdisciplinary approach thing. It's going to be kind of cool. Thanks for joining us today. And of course, thanks to our guest, Dr. Pete Anderson, for your work, for all you do to make it better. It's so much. And thank you for caring so deeply for your patients. We all know it and feel it and appreciate it. And thanks to our panelists, Ali Murdoff, Kara Skubris, and Delaney Sweet-Wernicke. You guys are awesome. And thank you guys for showing up and being here on OsteoBites as attendees as well. Really great questions and great to have you on. So looking forward to seeing you next week. Thanks, everybody. Be sure and subscribe to our YouTube channel where you can view our library of this and all OsteoBites topics and rockstar speakers. You can also listen to OsteoBites via podcast wherever you get your podcast.